Welcome to the Deep Dive. We're the show that helps you cut through the noise and really understand the important stuff. Today, we're taking a deep dive into a really significant piece of legislation from India, the Mental Health Care Act of 2017. This isn't just some dry legal document. Honestly, for too long, mental health was, hidden away, leading to isolation, lack of rights. But this act, it's more like a blueprint for a complete change in thinking. So our mission today is to pull out the key insights for you. We want you to understand how this act really aims to protect and promote the rights and dignity of people with mental illness.
Exactly. And it's important to see this in a wider context. This act aligns with global shifts, like the UN Convention on the Rights of Persons with Disabilities. It actually repeals India's older 1987 Act. So it's a very deliberate move away from an outdated model towards something modern and, crucially, rights-based. It's a real philosophical overhaul.
Okay, so let's unpack that. Before we get into the nitty-gritty of rights and rules, we need to understand how the act actually defines mental illness. I gather it's quite specific.
It is, and the language is careful. It talks about a substantial disorder. So not just any mood swing, but a significant issue with thinking, mood, perception, orientation, or memory. Something that, grossly impairs judgment, behavior, recognizing reality, or just coping with ordinary life.
Okay.
And, importantly, it does include mental health conditions tied to alcohol and drug abuse.
Right.
But here's a really key distinction for you. It specifically excludes what used to be called mental retardation. It separates developmental conditions.
That's interesting, separating those two. And this leads to something else I found really striking, the concept of capacity.
Yes, capacity. This is a game changer, really.
It seems like the act pushes back against the old idea that if you have a mental illness, you automatically can't make decisions for yourself.
Absolutely. The starting point, the default assumption in the act, is that every person, including someone with a mental illness, is presumed to have capacity. Capacity here means being able to understand the relevant information about a decision, appreciate the likely consequences, good or bad, and then communicate that decision.
Okay, but what if someone makes a decision that, well, maybe their family or doctor thinks is unwise or just wrong?
That's the crucial part. The act directly addresses that. It says that just because a decision seems inappropriate or unwise to others, that alone doesn't mean the person lacks capacity.
Right.
As long as they meet those core criteria, understanding, appreciating consequences, communicating their right to decide is protected. It's a massive shift towards autonomy.
A huge shift. So building on that autonomy, what if someone wants to plan ahead for a time when maybe they might lose capacity?
That's where advanced directives come in, a really powerful tool.
So like a living will, but specifically for mental health care?
Pretty much. Any adult can create one. You can specify in writing how you want to be treated, or importantly, how you don't want to be treated for a mental illness if you lose capacity later. You can even name the person you want to be your nominated representative in it.
And this only kicks in if capacity is lost.
Exactly. If the person regains capacity, the advance directive is paused, basically. Their current decision takes priority.
Can it be changed?
Oh, yes. You can revoke it or amend it any time while you have capacity. But one key point, it generally doesn't apply to emergency treatment situations.
Okay. And there are checks to make sure it was made freely.
Yes, medical professionals have a duty to follow it, but there's also a mental health review board. They can review an advance directive if there are concerns like if it wasn't made with free will, or if it's no longer relevant, or maybe conflicts with the law. But importantly, professionals acting in good faith based on an AD are protected from liability.
That makes sense. So you mentioned the nominated representative. Let's talk about that role. It sounds like having someone in your corner.
That's a great way to put it. It's about ensuring someone has your back. Every adult have the right to appoint one.
And if they don't?
The Act sets out an order. First, anyone named in an advance directive. If not, then a relative or a caregiver. If none of those are available or suitable, the board can appoint someone, even involving the director of social welfare if needed.
And what does this representative do?
Their duties are quite broad. They have to consider the person's wishes, their values, even their cultural background. They support the person in making treatment decisions, help them access information, get involved in discharge planning. But, and this is really crucial, appointing a nominated representative does not mean the person lacks capacity. It's just about having that support structure.
Okay. And for minors, is it just the parent or guardian?
Usually, yes. The legal guardian is the nominated representative for a minor. But the board can step in and appoint someone else if they find the guardian isn't acting in the child's best interests.
Got it. So we have Capacity, advanced directives, nominated reps, all empowering in the individual. Now let's get to the core, the actual Bill of Rights in this act. It seems pretty extensive.
It really is the heart of the act, yes. Section 18, the right to access mental health care, is foundational.
What does that mean in practice?
It means mental health services must be accessible, affordable, and good quality, and crucially, available without any discrimination: gender, sex, sexual orientation, religion, caste, disability, social status. None of it matters. The government is obliged to provide a whole range of services: outpatient, inpatient, halfway homes, specific services for children and older adults, and to integrate mental health into general health care.
Integration, that's key, not siloed away.
Exactly. And long-term institutional care. That's only meant for exceptional circumstances, really, as a last resort. The focus is community integration. The Act also says services should be close to where people live, aiming for at least one facility per district.
Wow, per district.
And here's a memorable detail for you. For anyone below the poverty line, or who is destitute or homeless, mental health care and services must be free of charge.
Completely free. That's huge. Okay, what about the right to community living? Section 19.
This tackles that historical issue of people getting, well, stuck in institutions.
Just because they had nowhere else to go.
Precisely. The Act explicitly states you can't keep someone in a mental health establishment just because they don't have family, or are homeless, or because community support isn't readily available. The government actually has a duty to support community-based living options. It's about ensuring people belong in society.
Right. And Section 20 talks about protection from cruel, inhuman, and degrading treatment. This sounds like it addresses some potentially dark history.
It absolutely does. It's about basic human dignity. It guarantees a safe, hygienic environment, sanitation, access to leisure, recreation, education, religious practices, privacy. But it also gets very specific, banning practices that, frankly, shouldn't have happened, like no forced labor. If someone chooses to undertake work, they must be paid fairly.
Okay.
And this might surprise you. No compulsory tonsuring that's shaving of the head. People have the right to wear their own clothes. And, of course, robust protection from all forms of abuse: physical, verbal, emotional, sexual.
Those specifics really paint a picture. Now, Section 21, equality and non-discrimination. Treating mental illness like physical illness. Sounds simple, but I imagine it's transformative.
It truly is. It means people with mental illness must be treated equally in all healthcare settings. Emergency facilities, ambulance services, even the living conditions in psychiatric units should be on par with general hospitals.
Equal standards.
Yes. And here's the aha moment, especially regarding access. The Act mandates that every insurer must provide medical insurance for treating mental illness on the same basis as they do for physical illness.
No more exclusions or higher premiums just because it's mental health.
That's the rule. Same basis. It's a massive step for reducing financial barriers.
Absolutely. Okay, moving on to information and confidentiality. Sections 22 to 25. Knowledge is power, right?
Definitely. The Act guarantees your right to know why you've been admitted, your right to have that admission reviewed, details about your treatment plan, including side effects, all in a language you can understand.
And confidentiality.
Very strong protections. Your mental and physical health information is confidential. There are exceptions, of course, like if there's a serious risk of harm to others,
Right.
or a court order, but they're specific and limited.
What about media? Privacy.
Crucially, no photographs or identifying information can be released to the media without the person's explicit consent. And that includes digital information, too. You also have the right to access your basic medical records.
Basic records, can they withhold things?
Yes, they can withhold specific information if the doctor believes it could cause serious harm to you or someone else, but you have the right to appeal that decision to the board.
Okay, appeals are possible. And what about staying connected? Personal contacts, communication, legal aid in sections 26 to 28.
Maintaining connections is seen as vital. So you have the right to receive visitors and also refuse them, and to make and receive calls and emails at reasonable times. Importantly, this communication cannot be restricted if it's with people like judges, board members, your nominated representative, or crucially, your lawyer.
Right, access to legal help seems critical for navigating all these rights.
It is, and the Act ensures a clear right to free legal services if you need them. Police, magistrates, medical officers, they all have a duty to inform people about this right and how to get that help.
And if things go wrong, service deficiencies.
There's a clear complaints pathway. First to the medical officer in charge, then escalated to the Mental Health Review Board, and potentially up to the state mental health authority if needed.
Okay, so that covers individual rights. Now let's look at the bigger system. Chapter 6 talks about the government's role beyond just providing care.
Yes, this is about fostering mental well-being across the whole population. The government, central or state, has a duty to plan and implement programs, not just for treatment, but for mental health promotion and prevention of mental illness.
Prevention? Like what?
Well, the Act specifically mentions programs to reduce suicides and attempted suicides, also creating public awareness campaigns to reduce stigma, and training officials, think police officers, for example, to be more sensitive and informed.
Sensitizing officials, yeah, that seems important.
And human resources, too. Training general medical officers in basic mental health care and aiming to meet international standards for specialist mental health professionals within 10 years of the Act coming into force.
So building capacity across the board. Who actually oversees all this? Chapter 7 and 8 mention central and state mental health authorities.
These are the main oversight bodies. They register the mental health establishment, set quality standards, maintain registers of professionals, advise the government on policy, conduct training, or the engine room, really.
And who sits on these authorities?
It's a mix. Government officials, naturally, mental health professionals, psychiatrists, clinical psychologists, psychiatric social workers, nurses, but critically, they also must include people with lived experience, those who have or have had a mental illness, plus caregivers, and reps from NGOs in the mental health field.
Lived experience at the table. That's significant.
It ensures the policies are grounded in reality.
Now, Chapter 11 introduces mental health review boards. You mentioned them earlier for appeals. They sound like the real guardians of rights at the local level.
They really are, where the rubber meets the road for individual rights. The state authorities set them up, usually for a district or maybe a few districts together.
And their makeup.
This is where it gets really interesting. Each board is chaired by a district judge or someone of similar judicial standing. It includes a government representative, a psychiatrist, another medical practitioner, and crucially, 2 members who are either persons with mental illness themselves, caregivers, or from relevant NGOs.
Again, lived experience built in.
Exactly. Their proceedings are considered judicial, like a tribunal. They're designed to be a quick response mechanism for complaints, appeals against admission, reviewing advance directives. They have specific, often short, deadlines, like 7 days for reviewing minor admissions, maybe up to 30 for some supported admissions.
And they have teeth.
Oh yes, they can impose penalties on establishments, order compensation, and even recommend canceling an establishment's registration if rights are violated or standards aren't met.
Okay. And the establishments themselves, clinics, hospitals. Chapter X covers them. What are the key rules?
The big one. No mental health establishment can operate without being registered with the relevant authority.
And registration isn't just a rubber stamp.
Not at all. They have to meet minimum standards for the building, the services offered, staff qualifications, record keeping, everything. These standards are set by the authorities. They face regular audits, usually every 3 years, plus inspections. Registration can be suspended or canceled if they fail to meet standards, violate patient rights, or if their management gets convicted of an offense under the Act.
So accountability.
Yes, and transparency, too. They have to display their registration certificate prominently, along with the contact details for the local mental health review board. They even have to provide the forms needed to apply to the board and allow free phone calls to the board for patients.
Free phone calls. Okay, that's practical access. Now, let's get into the specifics of treatment under Chapter 12. How does admission work?
The Act makes a key distinction. There are independent admissions. That's for adults with capacity who consent to admission. Then there are supported admissions for those who currently lack capacity, or for minors.
What happens with an independent patient? Can they just leave?
Pretty much. An independent patient can request discharge at any time, and generally they should be discharged. The medical officer can hold them for up to 24 hours for assessment if they think the person poses a risk to themselves or others upon leaving, but that's a short-term measure.
And minors. You mentioned that's highly regulated.
Very. Admission of a minor requires assessment and recommendation by 2 independent medical professionals, usually including a psychiatrist. And importantly, the minor's nominated representative, usually the guardian or another attendant chosen by the guardian, must stay with the minor in the establishment throughout their admission.
They can't be left alone.
Correct. And the board has to be informed within 72 hours of any minor's admission. For admissions lasting over 30 days, the board must conduct a review.
Right. Now, this next part seems incredibly important. prohibited procedures and strict controls on others, Section 96 onwards.
Yes, these are some of the Act's most powerful statements about humane treatment, drawing a clear line from past practices.
Like electroconvulsive therapy, ECT.
Okay, so ECT is permitted, but only with muscle relaxants and anesthesia. ECT without these is absolutely prohibited.
And for minors.
ECT for minors is banned, full stop. There's a very, very narrow potential exception involving multiple safeguards, specialist opinion, guardian consent, and prior permission from the Mental Health Review Board. But the default is a complete prohibition.
That's a strong stance. What else is banned?
Sterilization as a treatment for mental illness is prohibited. And maybe the most visually striking ban, chaining. The Act prohibits chaining in any manner or form whatsoever.
No chaining at all. Wow. But what about situations where someone is extremely agitated, potentially violent? How does the Act balance safety and rights then?
Okay, so the Act explicitly states there should be no seclusion or solitary confinement. That's out.
Right.
Physical restraint is allowed, but only as an absolute last resort. The threshold is high to prevent imminent and immediate harm to the person or others. It must be authorized by a psychiatrist, used for the shortest possible time, documented carefully, and never used as punishment or just because they're short-staffed.
An oversight.
The nominated representative has to be informed within 24 hours, and the person must be under continuous supervision while restrained.
What about emergencies outside a hospital setting?
Emergency treatment is defined very specifically, treatment needed immediately to prevent death, irreversible harm, or serious harm to self, others, or property because of the mental illness. Any registered medical practitioner can provide it, ideally with consent from the nominated rep if possible. But, and this is key, such emergency treatment is limited to 72 hours, and it cannot include ECT. It has to be directly related to managing the immediate emergency only.
72 hours max, no ECT, clear boundaries, and research. Section 99. Ethical considerations must be paramount.
Absolutely. Research involving people with mental illness needs their free and informed consent, just like anyone else. If someone lacks capacity to consent but doesn't resist participating, it gets complicated. Permission is needed from the state authority and consent from the nominated representative. Plus, strict conditions apply, like the research must have potential benefit for people with similar conditions and couldn't be done on people who can consent.
Protecting vulnerable participants. Makes sense. Now, the Act even broadens its scope to include the responsibilities of other agencies, like the police in Section 100. That feels like a significant shift.
It is. It changes the police role fundamentally in these situations.
Yeah.
If police find someone wandering who appears to have a mental illness and is at risk or unable to care for themselves, they have a duty to take them into protection.
Okay, protection, but what happens next? This is crucial.
Here's the aha moment. They must take the person to the nearest public health establishment for assessment within 24 hours. They're not to be detained in a police station or prison under no circumstances.
Not treated like criminals.
Exactly. If the assessment finds no mental illness requiring admission, the police help them return home or, if homeless, take them to a shelter. It's a healthcare response, not a law enforcement one.
That's a huge culture change. What about prisoners? Section 103 addresses those with mental illness within the prison system.
Yes, another vulnerable group. The Act mandates procedures for transferring prisoners who develop mental illness to proper mental health establishments for treatment. This could be a separate facility or a psychiatric ward within the prison itself. Medical officers in prisons have to send quarterly reports to the local board, certifying that no prisoners with mental illness are just being held in regular jail cells without appropriate care.
So active monitoring?
Yes, and the board members can actually visit prisons to check on the conditions and care for prisoners with mental illness. The government is also supposed to set up proper mental health facilities within the prison system in at least one prison per state or union territory.
Okay. And finally, perhaps one of the most talked about, most progressive parts of the Act, Section 115, the decriminalization of attempted suicide.
This is truly profound, isn't it? It tackles the immense stigma and misunderstanding around suicide attempts head-on.
So how does it work?
The Act states that anyone who attempts suicide is presumed, unless proven otherwise, to be experiencing severe stress. Well, because of that presumption, they shall not be tried or punished under the old section of the Indian Penal Code that criminalized attempted suicide.
So no prosecution.
Correct. Instead of punishment, the focus shifts entirely to care. The government has a duty to provide appropriate care, treatment, and rehabilitation to that person to reduce the risk of it happening again. It moves from a criminal justice issue to a public health and compassion issue.
A really humane approach. Okay, we've covered a lot of ground here, so let's try and synthesize this. What does this deep dive really tell us, the listener? This act feels, well, genuinely
It
transformative.
really is. It's a comprehensive framework moving India away from an outdated, often neglectful, institution-focused approach. It champions individual rights, dignity, autonomy, and recovery.
And its impact is broad, isn't it? Affecting individuals, families, doctors, insurers, hospitals, the police, the whole system.
Definitely. From the very definition of mental illness and recognizing capacity, through advanced directives, strong patient rights, non-discrimination, insurance parity, humane treatment standards, oversight boards, community focus, all the way to decriminalizing suicide attempts. It touches almost every aspect.
It brings mental health care firmly into a modern, rights-based perspective.
Exactly. It lays down a powerful, progressive legal foundation.
But that leads to the final thought, perhaps. For you, the listener, this raises a crucial question, doesn't it?
Hmm.
How does a society translate such excellent legislation into everyday reality? How do we ensure these rights aren't just words on paper, but are truly lived, experienced, and respected in clinics, communities, and families across the country?
That's the ongoing challenge, isn't it? Moving from law to lived experience, ensuring these principles are deeply woven into the fabric of care and societal acceptance. It requires constant vigilance, advocacy, and effort from everyone.